Welcome to Pharmacology Insights, where we break down complex pharmacology into simple, easy-to-understand concepts. If a 70-year-old woman and a 7-year-old boy both have a serious bacterial infection, same bug and same severity, can you just scale the antibiotic dose by body weight and call it a day? The answer is, absolutely not. Understanding why is one of the most vital lessons in pharmacology. In this video, we're looking at the two ends of the age spectrum, pediatric and geriatric patients. We're going to explore why giving either of them a standard adult dose isn't just a mistake, but can be genuinely life-threatening. There's an intuitive, but dangerously oversimplified idea in medicine that dosing is just a size problem. Smaller person, smaller dose. Bigger person, bigger dose. But drug behavior in the body has almost nothing to do with size alone. It's about physiology. The internal environment of a 2-week-old neonate, a healthy 30-year-old adult, and an 80-year-old with multiple chronic conditions are three completely different biological worlds. Today, we're going to explore both extremes. Pediatric, from neonates to adolescents. And geriatrics, generally those 65 and older. Both groups are pharmacologically special, but for opposite reasons. To understand why, we need to look at how drugs move through the body. Pharmacokinetics is what the body does to a drug. We break it down into 4 stages. Absorption is how the drug enters the bloodstream. This depends on things like stomach pH, gut motility, and skin thickness. Distribution is where the drug goes. Does it hide in fat or stay in the blood? Metabolism is how the liver chemically breaks down the drug to prepare it for exit. And lastly is excretion, mostly how the kidneys flush the drug out. Kidney function is everything here, though some drugs leave through bile, sweat, or breath. Every one of these stages is altered in a child. And every single one is also altered in the elderly. But the direction and danger? They couldn't be more different. Let's start with children. The golden rule of pediatrics is children are not small adults. They are rapidly developing organisms, with organ systems that are still maturing. Think of a neonate's physiology like a factory under construction. Some assembly lines aren't built yet, while others are running at half speed. Let's go through the differences in ADME. Let's first look at absorption. Newborns have less stomach acid, so a higher pH. That means the stomach is less acidic. For acid-labeled drugs, like some penicillins, this actually improves absorption. But for other drugs that need an acidic environment to dissolve properly, bioavailability drops. Gastric emptying time is also different. It's slower in newborns and matures gradually. And then there's the skin. Infants have thinner and more hydrated skin. As a result, transdermal absorption, or drugs absorption through the skin, is significantly faster. A topical steroid cream that's mild for you can be a massive systemic overdose for an infant. Next is distribution. Babies are essentially water balloons. They are 80% water compared to an adult's 60%. So, water-soluble drugs, like aminoglycosides, get diluted into that massive space. Meaning you might actually need a higher weight-based dose to see an effect. On the flip side, newborns have lower levels of plasma proteins, particularly albumin. Drugs that bind to albumin in the bloodstream are partially stored and inactive while bound. So, less albumin means more free drug, which is the active form, circulating in the blood. For drugs like phenytoin, an anticonvulsant, this can dramatically amplify both the therapeutic effect and the risk of toxicity. And then, there's metabolism. This is where things get really interesting, and really consequential. The CYP450 enzyme family, which handles most hepatic drug metabolism, is immature at birth. Some enzymes are nearly absent in neonates. Others ramp up rapidly in the first weeks of life. And the rest don't reach adult levels until adolescence. The maturation curve is different for every enzyme. This means predicting how a child will metabolize a drug requires knowing both the drug and the child's age. A particularly important example is what happened in the 1950s. The tragedy of gray baby syndrome. Doctors gave newborns the antibiotic chloramphenicol. Because their livers couldn't process it, the drug built up until the infants turned ashen gray and their circulatory systems collapsed. It was a heartbreaking reminder that protecting kids by excluding them from clinical trials actually made them therapeutic orphans. And last but not least, excretion. A neonate's kidneys are not fully functional at birth. Glomerular filtration rate, the key measure of kidney filtering capacity, doesn't mature until age 2. This means that renally excreted drugs clear much more slowly in young infants and accumulate to higher than expected concentrations. The aminoglycoside gentamicin is a classic example. It's an effective antibiotic against serious gram-negative infections, including infections common in newborns. But it's also nephrotoxic and ototoxic at elevated levels. If you're dosing gentamicin, you have to be incredibly precise. If the kidneys can't clear it, it builds up and can cause permanent hearing loss or kidney failure. And one critical clinical reminder: not all children are the same. In pharmacology, we subclassify pediatric patients into neonates, aged between 0 to 28 days, infants, aged between 1 to 12 months, toddlers and young children between 1 to 5 years, older children aged between 6 to 12 years, and adolescents between 13 to 17 years. The pharmacokinetics in each group can differ dramatically. A dose appropriate for a 10-year-old is not automatically appropriate for a 3-month-old. Now, let's shift to the other end of the spectrum, geriatric patients. If the challenge with pediatric patients is immaturity, the challenge with geriatric is decline. Systems that have been running for decades are beginning to slow down, atrophy, or fail. Let's look at the changes in ADME in elderly people. Of all the ADME stages, absorption is typically the least affected in elderly patients. Gastric acid production does decline with age, and gut motility slows. But these changes generally have modest effects on oral drug bioavailability. Next is distribution. This is where it starts to get complicated. As we age, we lose lean muscle mass and gain body fat. This matters enormously for lipophilic drugs, or drugs that dissolve in fat, like benzodiazepines and many anesthetics. These drugs preferentially distribute into fat tissue, creating a larger depot in the body. The result? Extended duration of action. A benzodiazepine that sedates a healthy 30-year-old for a few hours might sedate an 80-year-old for an entire day, or longer. Albumin levels also decline with age, particularly in patients who are malnourished or have chronic illness. As with pediatric patients, this increases the concentration of free drug in circulation, raising the risk of toxicity for highly protein-bound medications. And then metabolism. Hepatic blood flow decreases with age. The liver physically shrinks. CYP450 enzyme activity declines. The first pass effect, which the liver's chance to neutralize a drug before it hits the circulation, is weakened. So, more drug survives the liver, meaning a normal dose hits the bloodstream with unexpected force. Last, but not least, is excretion. This is the most critical concern. Kidney function declines with age, but blood tests can lie. Doctors look at creatinine, but creatinine comes from muscle. If a frail 85-year-old has very little muscle, their labs might look normal even if their kidneys are failing. This is a trap clinicians fall into regularly. Digoxin is a sobering example. Used for heart failure and certain arrhythmias, digoxin has a notoriously narrow therapeutic window, meaning the gap between an effective dose and a toxic dose is tiny. It's primarily renally excreted. In an elderly patient with declining GFR, which may not be apparent from serum creatinine alone, the drug builds up quietly until the patient develops life-threatening heart rhythms. Another critical factor to remember about the geriatric population is polypharmacy. Unlike normal kids or adults, the average elderly patient takes 5 to 8 medications. Each new pill is a fresh opportunity for a drug-drug interaction. This is why clinicians use the Beers criteria, a regularly updated red flag list of medications that are potentially inappropriate for older adults, covering everything from fall and confusion risk to GI bleeding, kidney injury, dangerous drug combinations, and much more. It's not a list of drugs you can never use. It's a prompt to stop and ask whether the benefit still outweighs the risk in this particular patient. Let's take a step back and look at both populations together, because this comparison really crystallizes the core lesson. In pediatric patients, every ADME stage is affected by immaturity. Systems that are developing, enzymes that haven't come online yet, and organs that are still learning their job. The direction of change is often unpredictable, and it shifts rapidly as the child grows. In geriatric patients, every ADME stage is affected by decline. Systems running slower, capacity reduced, and reserve depleted. The direction is more predictable. Things accumulate, and things slow down, but the degree varies enormously from patient to patient. Both groups were historically underrepresented in clinical trials, and both suffered because we tried to guess based on a 180-pound average male adult. So, how do we fix it? For kids, we don't just use weight. There are age-specific guidelines and therapeutic drug monitoring. Doctors measure the actual blood levels to ensure they aren't undertreating the water balloon phase or overtreating the immature liver phase. For seniors, the mantra is start low and go slow. Doctors calculate creatinine clearance rather than just looking at a lab report. They are also careful to treat every new prescription as a potential interaction. A drug dose is not just a number on a bottle. It is a clinical judgment that must account for where a patient is on the timeline of life. Whether it's a factory under construction or a system in its twilight years, both deserve the same level of precision. The next time you see a medication label, don't just ask how much. Ask who it was designed for. That distinction is the difference between a cure and a catastrophe. And that's it for today's pharmacology video. If you enjoyed this video, please give it a thumbs up and subscribe to the channel for more pharmacology content.